So we are going to study the final part, the part 4 of part 1 cardiology, and the first topic is hemodynamic changes in AV fistula. So what happens here is the fistula forms enlarged vein. This allows a portion of blood to bypass the high resistance of arterioles. So the systemic venous resistance decreases, and that decreases the afterload. If the systemic venous resistance is decreased, that decreases the afterload. And also the blood due to the fistula reaches the heart much more quickly and easily. This increases the preload. Increase in preload increases the cardiac output. Increase in preload increases the venous return. Increase in preload of course it is going to increase the cardiac output eventually, but in between, after the preload is increased, the venous return is increased, and there is decreased systemic vascular resistance. Why? The mean arterial pressure is equal to cardiac output into systemic venous resistance. So the decreased systemic venous resistance causes increased cardiac output. And now we are gonna study these hemodynamic changes in sepsis, injecting adrenergic agents, hypovolemia, and decompensated heart failure. Okay, so the hemodynamic changes in sepsis is the decreased afterload and decreased preload, which we saw earlier as well, that because of the low blood and fluid volume, the cardiac output initially increases to compensate that, but accumulation of cytotoxic mediators depress cardiac contractility and the heart rate. So next is injecting adrenergic agents like alpha and beta blockers causes vasoconstriction and arterioconstriction, which increases the cardiac contractility, that increases preload, afterload, and cardiac output. And then hypovolemia, decreased preload, decreased cardiac output, and then as a response the systemic venous resistance will increase, the afterload will increase. Decompensated heart failure, increased afterload, increased preload, but decreased cardiac output. Even with increased preload and increased afterload, the cardiac output is less because of left ventricle dysfunction. This is called low output heart failure. And then GARD versus MI. So the pain, the chest pain, how do you differentiate is the patient also has cough and hoarseness, occurs at rest or after meals, awakens patient from sleep. These are a few key points to note if it could be GARD, gastroesophageal reflux disease. And then QT prolongation. So QT prolongation is caused by hypocalcemia, hypokalemia, and hypomagnesemia. These are acquired causes: hypocalcemia, hypokalemia, and hypomagnesemia. And the other causes, other acquired causes, are antibiotics like macrolides, fluoroquinolones, psychotropics like antipsychotics, TCAs, SSRIs, opioids like methadone, oxycodone, antiemetics like ondansetron, granisetron, and antiarrhythmics like quinidine, procainamide, flecainamide, amiodarone, and sotalol. I don't know how I'm gonna remember all this, which if I need to have more details in the question to actually figure out it is the QT prolongation or actual ECG itself. And it is also seen in inherited causes like Jervell-Lange-Nielsen syndrome, which is an autosomal recessive disorder, and Romano-Ward syndrome, which is an autosomal dominant disorder. So normally what happens in QT prolongation is, after depolarization, the voltage gated K plus channel opens and the K plus leaves the cell. This repolarizes the cell. However, in QT prolongation, when it's abnormal, the K plus efflux is delayed. So repolarization takes longer, prolonged action potential and prolonged QT interval. However, the depolarization action impulses are coming from the atria, so the early Depolarization occurs before even the cell fully resets. This causes abnormal beats and re-entry circuits. This causes polymorphic VT, torsidus de pointis. So QT prolongation eventually goes to torsidus de pointis and other ventricular arrhythmias. The next one is complications of cardiac catheterization. So the complications of cardiac catheterization is the most important one, which happens within 12 hours of the catheterization, is retroperitoneal hematoma and bleeding. It happens within 12 hours. The investigation of choice is non-contrast CT scan of abdomen, and the clinical presentation is hemodynamic instability and flank back pain. Clinical presentation is hemodynamic instability. If the patient has hemodynamic instability and flank back pain within 12 hours of catheterization, then it could be retroperitoneal hematoma, and bleeding also happens within 12 hours of catheterization. The cause of retroperitoneal hematoma is that if puncture site is above the inguinal ligament, hematoma extends to retroperitoneal space even with minimally visible hematoma. So if the puncture site above inguinal ligament is above the inguinal ligament, hematoma extends to retroperitoneal space even with minimally visible hematoma. That's why radial artery approach has fewer, we use radial artery approach that has fewer local vascular complications, which has fewer local vascular complications. So the other important complications of cardiac catheterizations are arterial dissection, acute thrombosis, pseudoaneurysms, AV fistula formulation. The next one is tricuspid regurgitation. Tricuspid regurgitation almost presents very similar to cardiopulmonale. It's a severe right-sided heart failure, which is cardiopulmonale as well. And the clinical features are distended jugular veins, pulsatile and intender hypertrophy, hepatomegaly, abdominal distension with ascites and pulmonary edema, lower extremity edema. Cardiac examination reveals exactly the same: right ventricular heave, hollow systolic murmur. Murmur intensifies with maneuver that increases the right ventricle preload. So the next topic is coarctation of aorta. The pathology is that thickening of tunica media of aortic arch. This can be associated with Turner syndrome and bicuspid aortic wall. Turner syndrome has coarctation of aorta. And bicuspid aortic wall. Clinical features would be increased BP and strong pulses in upper extremities, low BP and weak pulses in lower extremities. If it is severe, then it is presented in the neonate stage as well. Poor feeding and diaphoresis, heart failure and cardiogenic shock. If the narrowing is mild, then it is presented when the patient is children, and there you see lower extremity claudication, pain, cramping and tiredness in leg, palpable pulsation of intercostal vessels, secondary hypertension, upper arms. High BP in upper extremity, low BP in lower extremity. Turner syndrome, bicuspid valve. And the complications are aortic aneurysm, dissection and rupture, cerebral aneurysms and subarachnoid hemorrhage as well. Treatment is PGE1 for neonates with severe narrowing, prostaglandin for neonates with severe narrowing, and surgical repair. The final one is mitral regurgitation, tricuspid regurgitation. We saw about the right-sided heart failure. So most cause of mitral regurgitation is mitral valve prolapse. We see mid-systolic click and mild to late systolic murmur, which we saw earlier in mitral valve prolapse. Severe people develop hollow systolic murmur. Chronic severe mitral regurgitation causes left atrial and left ventricular dysfunction, and then heart failure, congestive heart failure. Yeah, I guess that is part 4. I think I would have done it with the part 3 itself, but I got so tired and I could not revise anymore. So I took a break and now it's again done. So now I'll go back and study all the 40 questions from which these topics came. And as always, let's hope we all pass the exam. Peace.